The topic Polymyalgia Rheumatica in the Rheumatology module. By the end of this topic, you should be able to define Polymyalgia Rheumatica, explain the pathophysiology of this disease, outline the causes and classification, describe the clinical manifestations of Polymyalgia Rheumatica, outline the investigations to diagnose, assess the severity and monitor the response to therapy, discuss the principles of management, and explain the complications and prognosis of Polymyalgia Rheumatica. Let's get started. Polymyalgia Rheumatica is a syndrome with pain or stiffness, usually in the neck, shoulders, upper arm, and hips, but which may occur all over the body. This term is derived from the breakdown of the word poly, which refers to many or much, and myalgia, which means pain in the muscles. Similar to other autoimmune diseases, in Polymyalgia Rheumatica, genetic predisposition and environmental factors cause monocyte activation and the production of cytokines that induce manifestations characteristic of Polymyalgia Rheumatica. Interleukin-6 appears to have a central role in mediating inflammation. In brief, it causes inflammation of the large muscles of the body and can be accompanied by systemic symptoms including malaise, fatigue, fever, and weight loss. As for the joints, the synovial membranes and bursa that line and lubricate the joints become inflamed, causing pain and discomfort. Next, we'll look at the causes and risk factors. One of the causes is viral infections such as adenovirus, human parvovirus B19, and human parainfluenza virus. Next, it could also be due to genetic predisposition and particularly HLA-DR4 type of human leukocyte antigen are most commonly related to this disease. Age with 50 years or older is also one of the factors that leads to this condition. For classification criteria, according to the European League Against Rheumatism and American College of Rheumatology, there is required criteria and criteria for scoring algorithms. Required criteria include age more than 50, bilateral non-shoulder pain, and abnormal ESR or CRP. For criteria for scoring algorithm, it includes both clinical and ultrasound criteria. More of the details can be referred to the attached table. Using a combination of critical criteria and ultrasound criteria, a score of more than 5 is needed to come to the diagnosis. Here are some of the symptoms of Polymyalgia Rheumatica that patients can be presented with. Firstly, there's symmetrical pain and stiffness in and around the shoulders, neck and hip girdle, especially in the morning, and also worsens after rest or prolonged inactivity. Next, there is also restricted range of motion of the shoulder. The patient might also experience weakness, fatigue, and malaise. Then there might be low-grade fever and patient may suffer from weight loss and vision changes. In terms of psychiatry, patients might also suffer from depression. Here are some of the signs of Polymyalgia Rheumatica that patients might complain of. There is diffuse tenderness over the shoulder without localization, and the pain usually restricts the active shoulder range of motion and passive range of motion could be normal. Subsequently, there's restriction of neck and hip movements because of pain. Next, patient may complain of muscle tenderness of the neck, arms, and thighs, however, muscle strength is usually intact. In the later stages, there's disused muscle atrophy with proximal muscle weakness. And at the same time, contractures of the shoulder capsule may lead to limitation of passive and active motions. The pathognomonic sign of Polymyalgia Rheumatica is temporal arteritis, where there's headaches, scalp tenderness, jaw or facial soreness, distorted vision, or aching in the limbs caused by decreased blood flow. Diagnostic investigations to be done are CRP, which is expected to be elevated, and erythrocyte sedimentation rate, which is expected to be more than 40 mm per hour. For bedside tests, urine analysis is done to check for any hematuria or proteinuria to rule out small vessels vasculitis. Next, blood glucose test is done as the baseline for the mainstay steroid treatment. There are several lab investigations that can be carried out. Firstly, rheumatoid factor and/or anticyclic citrullinated peptide antibodies tests show negative results. C-reactive protein and/or erythrocyte sedimentation rate might be elevated. Next, full blood count with differential pneumocytic pneumochromic anemia, and in most patients, leukocytosis and thrombocytosis reflecting systemic inflammation. However, CK is normal to differentiate polymyalgia rheumatica from polymyositis and other primary myopathic disorders. For imaging studies, bone radiographs show evidence of osteoarthritis, while ultrasound shoulder abnormalities such as bursitis and tenosynovitis of the long head of the biceps tendon. For functional studies, synovial fluid analysis shows synovitis with mild inflammation and poor mucin clotting. Next, bone profile shows osteopenia or osteoporosis. For management, particularly medical therapy, firstly, administer corticosteroids such as prednisolone with rapid response usually in 2 to 4 weeks. Subsequently, if symptoms improve, then slowly taper and eventually stop glucocorticoids. However, if there is no improvement after 2 weeks or relapse, hence increase the dosing. Calcium and vitamin D supplementation can also be administered. As for physical therapy, there is no particular limitation to activity. Complications of polymyalgia rheumatica include premature atherosclerosis resulting from chronic inflammation, and it's the most likely cause of premature coronary artery disease. It can also cause inflammatory arthritis with features of small joint synovitis, younger age, and positive anti-citrulline peptides positive or anti-CCP positivity. With early diagnosis and correct therapy, patients have an excellent prognosis with average length of disease being 3 years. However, exacerbations may occur if steroids are tapered too rapidly and relapse is common. In short, polymyalgia rheumatica is a relatively common chronic inflammatory condition of unknown etiology that affects elderly individuals. It is characterized by proximal myalgia of the hip and shoulder girdles with accompanying morning stiffness that lasts for more than 1 hour. Polymyalgia rheumatica is a clinical diagnosis based on the complex of presenting symptoms and the exclusion of other potential diseases. Commonly, corticosteroids are considered the treatment of choice, and a rapid response to low-dose corticosteroids is considered pathognomonic. Therefore, usually patients have an excellent prognosis. Exacerbations may occur if steroids are tapered too rapidly, however, and relapse is common. We have come to the end of this topic. Thank you.